This is our critique of the article Cost-Effectiveness Analysis of Sacubitril/Valsartan versus Enalapril in Patients with Heart Failure and Reduced Ejection Fraction by Kelsey, Cosette, and Joan.
Is the title appropriate? From reading the title, it can be determined what is being compared, sacubitril/valsartan versus enalapril, and what type of study is being conducted, a cost-effectiveness analysis. The title does not seem biased, as it does not imply favoring one over the other. Is a clear objective stated? The objective from the abstract reads that the objective is to estimate the cost-effectiveness of sacubitril/valsartan versus enalapril in the United States. It is clearly stated and answers the well-defined question. Is sacubitril/valsartan cost-effective in patients with heart failure with a reduced ejection fraction? For a little background on the medications and the methods of the analysis, sacubitril/valsartan, brand name Entresto, is indicated to reduce the risk of cardiovascular death and hospitalization in patients with chronic heart failure, NYHA class 2 through 4, and reduced ejection fraction. It was approved by the FDA in July of 2015 and was newly incorporated into guidelines as an alternative to ACEs or ARBs to reduce morbidity and mortality. It is the only combination of valsartan plus sacubitril, a neprilysin inhibitor. This pharmacoeconomic analysis used data taken from participants of the PARADIGM-HF trial, which found that enalapril and Entresto had similar benefits for cardiovascular mortality. Entresto was found to be superior to an ACE inhibitor alone in decreasing the risk of death and hospitalization related to heart failure. The authors used this data to develop a two-state Markov model simulating heart failure. The population had equivalent characteristics to the PARADIGM-HF population and simulated costs and health consequences for 30 years. Were the appropriate alternatives or comparators considered? The study did consider appropriate alternatives and comparators. Entresto was compared to one of the next best alternatives, since an ACE inhibitor such as enalapril is recommended for all patients with heart failure with reduced ejection fraction, unless contraindicated to reduce morbidity and mortality per the 2013 ACCF-AHA guidelines. Was a comprehensive description of the competing alternatives given? Yes. The description and specific doses and duration of therapy were included so that the study could be easily replicated. The study compared 97 milligrams of sacubitril and 103 milligrams of valsartan twice daily with enalapril 10 milligrams twice daily, both for a treatment duration of 30 years. Equivalent doses of the drugs cannot be directly converted, but doses of both drugs are within the normal recommended dosing ranges.
Is the perspective of the study addressed? The perspective of the study was not explicitly stated. However, the researchers reported measuring the life years gained with taking Entresto and reductions in hospital admissions and the potential savings. So we assume that the perspective is that of the patients and of the hospitals. Is the type of study stated? The paper correctly identified the study as a cost-effectiveness analysis because it measures outcomes in natural units, such as ejection fraction and life years gained. It could also be considered a cost-utility analysis because the researchers also used quality-adjusted life years to measure the effectiveness of the treatments, but the authors do not directly state this. Were all the important and relevant costs included? The relevant costs were included, such as cost of medications and hospitalizations. The monthly cost of using Entresto was $375 compared to enalapril, 96 cents. And the mean cost of hospitalizations for heart failure was around $18,000, whereas for non-heart failure, it was around $10,000. The types of costs assessed were appropriate and sources used to estimate costs were referenced. The costs of the medications were based on wholesale acquisition costs for each drug, and hospital costs were estimated from private insurance rates as well as Medicare rates. Indirect costs should have been included if the authors wanted to use a societal perspective, but this was not addressed. Were the important or relevant outcomes measured? Outcomes were measured as mortality, hospitalizations due to heart failure, quality-adjusted life years, and cost of hospitalizations and treatments. These outcomes are important to clinicians and were projected out to 30 years, which is an appropriate time period for chronic medical conditions. When compared with enalapril, sacubitril/valsartan extends life, reduces hospitalizations, and has an incremental cost-effectiveness ratio of $45,000 per quality-adjusted life year gained in the United States. Was adjustment appropriate? If so, was it conducted? Was discounting appropriate? If so, was it conducted? Discounting was conducted appropriately for both costs and quality-adjusted life years, as they were based on future benefits. A discount rate of 3% was used per the recommendation of the U.S. Panel on Cost Effectiveness in Health and Medicine. The author states that they did not take into consideration possible decreases in the cost of Entresto after its patent expires in 2023.
Reasonable assumptions. Are assumptions stated and reasonable? The assumptions are reasonable as the model used by the study was based off of results from the Paradigm-HF trial. The researchers found the ICERs to be cost-effective, and the results were confirmed with results of other cost-effectiveness evaluations. Sensitivity analysis. Were sensitivity analyses conducted for important estimates or assumptions? The researchers conducted sensitivity analyses for key outcomes, including hospital costs, mortality benefits, hospitalization drug costs, and quality of life, and they found that the results of the study were relatively insensitive to the cost of either drug. The values were varied for all of the variables, and the ICERs consistently stayed below the willingness to pay, which is set at $150,000 for a quality-adjusted life year. Further details of the sensitivity analysis can be seen in the tornado diagram we have here. Were limitations addressed? Yes, the authors did acknowledge the limitations to their study, including the assumption that the medications were tolerated with no adverse effects, and they also only included the US in their research. Appropriate generalizations. Were extrapolations beyond the populations studied proper? The authors noted that the study only evaluated the cost-effectiveness of Entresto in the United States, so individual analyses would have to be conducted in order to generalize the cost to other countries. The patient population included is patients with LVEF less than 40% and within the NYHA classes 2 to 4. And this is representative of the patients that would be indicated for and treated with Entresto. Unbiased conclusions. Was an unbiased summary of the results presented? We found that the conclusion was unbiased as the authors conclude that sacubitril/valsartan is cost-effective per the conducted analysis, but does not overstate or over-extrapolate the data presented in the results section. They chose appropriate alternatives and used unbiased, reasonable estimates when determining the results. The authors determined that sacubitril/valsartan is cost-effective and could prevent thousands of deaths and hospitalizations in patients with heart failure. It has an ICER comparable to other accepted interventions at a generally accepted willingness to pay. Overall, found that this study was unbiased, didn't over-extrapolate the data, and is believable. Here are our references.